Thanks, Sunil, for that introduction. With the advent of OCT, definitely the one retinal disorder which has been we had started to detect more and started to treat more with prognostically and as well as for the better treatment, that is the vitreomacular interface. Let me go through some other things. I don't have any financial interest regarding this presentation. So as I told before, most of the retinal disorders with the advent of 3D OCT or spectral domain OCT, we can diagnose better the vitreomacular interfaces. We can follow up them pre-surgically, pre-treatment and post-treatment. Basically the surgical is the main modality of treatment. And the association of vitreoretinal interface changes in various other retinal pathologies can be assessed with this. Definitely with the advent of spectral domain, there is an improved resolution and speed of image capture is increased, so we are able to detect much more subtle changes than in earlier things. What is this vitreomacular classification? And basically it's a spectrum of diseases. The one common finding for all these disorders is what is known as VMA, that is a vitreomacular adhesion. So vitreomacular adhesion is one of the significant finding in this. If it becomes a pathological, leads to some of the diseases like vitreomacular traction. Can I have a pointer, please? Vitreomacular traction, the macular hole, some of the diseases has already been dealt with. I'll be dealing with in the little bit overlap that. Then there is an epiretinal membrane, then the condition known as in high myopes, this is known as the myopic macular schisis and lamellar macular hole. So this is a spectrum of diseases. I'll be telling you about one by one, so to go through in details. So as I told, the main culprit here is the in abnormal interface is the anomalous PVD or a posterior vitreous attachment, which occurs because of the vitreomacular adhesion. So the anomalous PVD leads to all these things and leads to a spectrum of diseases which may range from a lamellar hole, macular pucker, full thickness macular hole, VMT and other things. So what is this anomalous PVD? This is a persistent vitreous traction on the fovea or on the disc that could be associated with epiretinal avascular proliferation. So what is the significance of knowing all these things? The one is they bring about structural changes in the retina, all these tractions. Basically it would be in the form of retinal distortion, retinal thickening, inner cyst formation, the formation of a subretinal fluid or schisis. I told there is a splitting of retinal layers. So these structural changes can be well imaged with the 3D imaging or with the spectral domain OCT. In the end stages, there could be a consequence of a macular hole formation in sometimes. So as I told, it could be an asymptomatic vitreomacular adhesion is the main cause for this. Is nothing but a perifoveal PVD, and most often it will be asymptomatic. And if you go by the Johnson's classification of PVD, this vitreomacular adhesion corresponds to the stage 1 of the PVD, and most of these patients will be asymptomatic. The VMA has been further subclassified based on the extent of adhesion, that is into focal as well as the broad attachments. Where there is a focal VMA when it is less than 1500 microns, and the broad VMA when it is more than 1500 microns. It could be also classified as isolated and concurrent. What does it mean is, in a concurrent it will be associated with other retinal abnormalities. As I told, the focal is associated with less than 1500 microns. So results in a focal macular pathology in the form of VMT. There could be associated cystoid spaces, subretinal fluid, and as I told, the consequence, these are all the structural changes which occurs. The diameter of the vitreomacular attachment is inversely correlated with the macular mobility and the foveal formation, means the degree of attachment and the degree of thing certainly correlates with the structural changes which occurs in the macula. Similarly with the broad attachment, the changes seen commonly are, there could be broad attachments are commonly seen with epiretinal membrane, tractional macular detachments, myopic foveal schisis, that is myopic macular schisis, also known as tractional things, and concurrent disorders like diabetic macular edema, AMD and retinal vein occlusion most often will be associated with the broad attachments than a focal vitreomacular tractions. So VMT is nothing but a pathological VMA. So symptomatic VMA is nothing but a vitreomacular traction. So it is most often pathological, so it could be associated with, I told, all these structural changes. VMT was noted in 8% of the patients with ophthalmoscopy alone, compared with, if you do an OCT evaluation, more than 30% of the same patients we could have detected a VMT. So OCT does play a significant role in detecting these pathological conditions. So again, the classification is similar to VMA. In VMT, it is focal or broad, and it could be isolated and concurrent with associated other disorders. So incomplete vitreous detachment. So there are other further classification of VMT based upon whether there has got a complete nasal attachment and temporal attachment. Two patterns have been described. The first group is There will be an incomplete vitreous attachment nasally and temporally, so there will be a V-shaped configuration of VMT. The other pattern which is described is the second group had a persistent nasal attachment, but temporally it is the PVD would have already occurred. So the second group is a J-shaped configuration. What is the relevance of this? The specific preoperative OCT patterns of VMT may be useful in predicting the outcome. For example, the first group, that is a V pattern group, did better on a post-operatively with the restoration of retinal architecture and improved vision when compared to the second group, which is the J-shaped pattern of the VMT. So it does help in assessing the prognosis and the outcome. So another thing is, in a study has been shown that 36 sites with idiopathic VMT syndrome propose an high correlation between the focal V-shaped VMT and the broad J-shaped. If you look at, I told the prognostically V-shaped one is a better. Similarly, the focal adhesions are more common with V-shaped and the broad VMTs are more associated with the J-shaped pattern. The second thing is, the classification of VMT by considering the diameter of adhesion and not its pattern might better predict. So the diameter of vitreomacular adhesion or VMT is more critical in assessing the prognosis than its pattern, V or J shape, but definitely V and J pattern also contributes for this. So of course the clinical course we can follow it up, whether it results in a complete resolution physiologically or progresses the formation of a macular hole, lamellar or a full thickness macular hole. The other thing is, so in conclusion in VMT, the VMT helps, basically it helps in pre-surgical planning, and the other thing is the associated concurrent abnormalities along with the VMT. It has been shown that there is an high correlation between epiretinal membrane and VMT, so both these are sometimes can be overlapping findings. So as told before, there is a segmentation of each layer, you can get the thickness maps using a 3D imaging, but the outer layer changes correspond is of more relevance to us than but in the vitreomacular layers, we can assess each layer separately. That is the retinal thickening, RNFL, RP thickness map, and RP deformation maps. Another important thing in VMT is quantification of the cyst volume. The most often structural changes may induce a cystoid macular edema. You can in fact quantify the cyst, how much is the volume of the cyst, and the other things, and is there any connecting tissue between the cystoid spaces. You can see the cystoid spaces. The tractional forces exerted by the vitreous and the inner retina becomes apparent in this inferior oblique view as shown by these blue arrows. So these are the cystoid changes which can be quantified with the spectral domain OCT. This is an automated segmentation image where the cystoid spaces are shown in yellow, the posterior hyaloid shown in blue color, and the inner limiting membrane sandwiched in between is shown in the green color. So this is how you can quantify the cystoid spaces, and the canal-like connection sometimes can be made out between the cystoid spaces as shown in this by red arrow. So it does give us an additional information. And the other important thing is we can make out sometimes you can get the end-phase imaging also, so that you can get both the transverse tractional forces also can be better made out than the routine conventional imaging. So it helps in diagnosis, prognosis, therapeutic, basically pharmacological, because if you look at the microplasmin studies, the pharmacologically we can treat the patients with VMT so that you can serially follow up the patients with OCT for therapeutic treatment with the pharmacological agents also. So broad-based vitreous adhesions tends to have a less of a visual benefit after surgical repair, while patients with cystoid macular edema tends to do the better. There's a conclusion of this, of the OCT studies have shown that the patients with cystoid macular edema tends to have a better visual acuity than the broad-based adhesions. Coming on to the other entity, common macular hole, which has been dealt already by previous speakers, but some additional things which I would like to discuss about the macular hole here is the macular hole can be classified based on the aperture size. Earlier we used to look at the classical gas classification of stage 1, 2, 3, 4. But we can classify based on the aperture size of the macular hole into small, medium and large, whether it is 250 microns, more than 250, about 250 to 400, more than 400 microns. So why did we consider this 250 and 400 microns is based on the ocular study data, which suggests that the best results for small macular holes are seen when the hole size is less than 250 microns. Further, the macular hole prognosis is also assessed by whether the VMT is present or not. You can see here the macular hole, small full thickness macular hole where the VMT is present. The other thing which can be is sometimes it can be associated with the secondary changes. If there is a secondary full thickness macular hole, you can look at the way the OCT has changed, where we look at it. This is the OCT world based classification of the gas. This is a stage 0. We used to neglect such cases before. The stage 0 macular hole is where there is a VMA is seen in the contralateral eye. This is the relevance of imaging a contralateral eye, which gives us a clue or a prognostically how well you can follow up the other eyes, so that it gives a clue that when the patient can progress to a full thickness macular hole. Similarly, stage 1 there will be VMT. The stage 2 and all these correspond to this, and the stage 4 will be associated with full thickness macular hole with a vitreomacular adhesion release, and it can be either small, medium or large holes. So it helps in accurate staging. The surgical closure can be assessed. You can assess the various indices which has been described, and you can differentiate between a lamellar hole and a true hole. As Uni has rightly pointed out, the structural integrity of the photoreceptors, cost and other things can predict the outcome. But another important thing which has been described is the premacular hole foveal anatomical configuration. What is the relevance of this? The distinct macular configuration may allow us to early diagnose, close follow-up and better management of macular holes. Steep, non-symmetrical foveal slope with wide fovea on OCT scans as seen. 50% of such patients with such configuration will tend to develop a macular hole if you closely follow up such patients. Of course, end-phase case imaging can give a transfer scans, and the other dimensions can also be picked up in early stages. Coming on to the epiretinal membrane, what additional points we can study with this is one thing is we can know whether it is a focal or globally adherent epiretinal membrane. It could be primary ERMs are more tend to be globally adherent. Secondary ERMs tends to be focal when compared to the other things. We can know the membrane thickness, underlying macular thickness. We can differentiate between posterior hyaloid from an ERM and the vitreoschisis associated with this. So what is how surgically it helps? Basically, it helps in detecting the edge of the ERM, the layers beneath that. So, is there any structural changes? All these things has been stressed out, the ISOS junction. But one important thing is metamorphopsia induced by ERM may be related to the edema in the inner nuclear layer. So the classification of ERM based on the inner nuclear layer edematous thickness may be potentially useful in especially who are symptomatic and following up such patients. Of course, this is a patient with a focal ERM and this is a globally adherent ERM. Another classification of ERM has been done based on the OCTs, whether the first type is the diffuse type, the second type is the cystoid type of ERM, the third type is the pseudolamellar type, and the fourth type is VMT. So what is the relevance of this? The surgical intervention for pseudolamellar type was not associated with visual improvement as seen with other type. The VMT type had the highest reoperation rate. So you can assess the prognosis in ERM patients whether which type of ERMs will do better surgically or with the prognostic aspect. Of course, the end phase has got a role in, you can find out the radial lines and the tractional extent can be sometimes much better seen on a end phase imaging, and it can be a useful additional tool compared to the conventional scanning. As told before, many disorders, the pathogenesis can be correlated, or the prognosis and the treatment can be associated with the vitreomacular interface abnormality changes. But I would like to stress few points about that. The one important clinical entity is the high myopia, where vitreomacular interface has made a lot of changes. In myopia, the inner retinal layers are contracted either by a taut posterior or ILM. Partial or full thickness macular holes all these are the pathological changes which occurs in myopia. But the one important thing which has been described in literature and more talked about nowadays is the myopic tractional maculopathy, also known as myopic foveal schisis. Tightening of the ILM causes the detachment from the macula, and OCT sometimes can reveal an ILM detachment in a myopic patient. So you can see here spectral domain image of a patient with an eye myope with a posterior cephaloma demonstrating a myopic foveal schisis. This is as shown by a large arrow. So it may be associated with foveal detachment and other changes. So sometimes this entity was neglected more. With the advent of the OCT, we are looking more into towards such patients. The schisis can be sometimes an inner schisis, outer schisis, or a combination of these. DME has been dealt with Dr. Manoj. I will not be going into the details of this, but one significant thing I would like to say is, in a DME with an OCT study, it has been shown that most central macular traction was seen in almost 25% of the patients, and extrafoveal traction was seen in 10.8%. As high as 30% of the patients with DME could be associated with the epiretinal membranes. The another entity which we looked at is Dr. Manoj has really pointed out the classification of DME based on the tractions, whether it is a minimal traction, questionable traction, or evident traction. But another thing is that we looked at the further classification of DME based on the OCT. So eyes with, as we really know that the eyes with DME have got a low incidence of posterior vitreous detachment. So it has been further classified those with taut posterior hyaloid, those with vitreomacular and vitreofoveal tractions. Then there is an entity which has been described post vitrectomy in a diabetic macular edema patient. There could be a taut ILM which can cause the further worsening of the diabetic macular edema as seen here. So there is a relevance of OCT post vitrectomy also in a diabetic patients in a diabetic macular edema. You can diagnose the taut ILM also. So these are some of the prognostically it's very, very important. See, in various disorders it has been described, but most important thing is conditions like AMD, the role of anti-VEGFs, whether the prognostic anti-VEGF, how well it works, can be decided based upon the vitreomacular interface abnormalities. The another entity is the venous occlusions, and this is an evolving process of various retinal disorders when the role of vitreomacular interface has been studied. And some of the commonest things would have been the diabetic macular edema and exudative AMD. So in conclusion, the OCT can detect the evolution of PVD, whether it is a symptomatic or anomalous PVD with the macular structural complications. We can plan the surgical intervention, we can assess the prognosis, and this is an evolving process, and which much more literature studies are going on regarding the various retinal disorders and the role of vitreomacular interface associated with this. Thank you.